Is it live now?
Yes, sir. So it's 3, 2, 1. Over to you, sir. We have live to audience, sir.
Hello, everyone, and very good evening to all of you. I am Dr. Gajanan Panchal, pharmaceutical physician and medical advisor for Lupin. And on behalf of Lupin, I extend very warm welcome to you all in today's webinar series, Gut Connect.
Yes, sir.
So Gut Connect is the webinar series, and under this series, we are holding the first interface webinar for physicians and specialists in gastroenterology dedicated to advancing knowledge and management of functional dyspepsia with special focus on PDS. So in true sense, Gut Connect is creating imprints in the field of gastroenterology. As doctors, you all know that Lupin holds strong presence in the field of gastroenterology over decades. And Lupin pioneers in creating scientific programs and initiatives to disseminate knowledge across spectrum of GI diseases. And we are proud to announce our faculties for today's event from renowned hospital, Fortis Memorial Research Institute, Gurugram. We are highly privileged to have Dr. Professor Gauda Chaudhary, who is renowned gastroenterologist and a great teacher, as a chairperson for today's event. Dr. Chaudhary is associated with Department of Gastroenterology and Hepatobiliary Sciences at Fortis Memorial Research Institute, Gurugram. Dr. Chaudhary was the first to start endoscopic ultrasound and extracorporeal shockwave biliary lithotripsy in India. Dr. Chaudhary has played a leadership role in developing liver and digestive healthcare in the country and has served on boards of several scientific bodies and journals. He has over 200 scientific publications as well as several orations and awards to his credit. Welcome, sir, on board. So now, without further ado, I will hand over the session to Dr. Chaudhary for further proceedings. Over to you, sir.
Thank you, Dr. Gajanan, and a very warm welcome to all my physician colleagues who are joining in. Very hearty welcome to each and every one of you. This topic is fairly common. In fact, I requested recently somebody to do a kind of a little survey with physicians as to what are the commonest problems they face in their day-to-day practice. And I was surprised that topping the list was actually dyspepsia, and followed by, of course, bowel disorders like irritable bowel syndrome. So that's the way it is, and we all seem to think that it's something common, so it's easy to manage. But let me tell you honestly, I find it very difficult to manage it, because you can be, if you don't understand the little nuances of which one to be treated how, you often are not getting a very rewarding response from the patients. Okay, so today we have two very eminent experts to talk us through this very seemingly easy but complicated topic, and both of them are stalwarts in their fields. So our first speaker will be Dr. Zubin Sharma. He is a senior specialist in gastroenterology at the Fortis Memorial Research Institute. He has got a particular interest in GI physiology. Most of you who know that, he's already at a young age started doing quite a bit of manometry and GI physiology studies, published a bit. And he is going to talk to us a little bit as to how to diagnose it, what is it all about, and so on and so forth. It has to be more than just an acronym of functional dyspepsia. And the next speaker is Dr. Rinkesh Bansal, a very senior person. He's the associate director in the Department of Gastroenterology and Hepatobiliary Sciences at Fortis Memorial Research Institute. He's got very vast experience, lot of publications. He's a very sought after speaker in many international conferences. So he'll be talking to us about how exactly to manage it at a more, shall we say, how to tweak which one to treat how, that kind of a thing. so that all of you are fairly educated about it. So with those introductory remarks, we'll just jump in. So may I first request Dr. Zubin Sharma to come and tell us what it's all about. I'm sure hopefully he'll make it simple yet understandable, because sometimes, GI physiology can be a little technically challenging. But after that, once we understand, it will probably be easier for us to know how to manage. Over to you, Dr. Zubin Sharma.
Thank you so much, sir, for those kind words. I'll just share my slides. So what I'll try to do is I'll try to show or highlight an approach to dyspepsia. So whenever I speak on dyspepsia or I read about it, one of the first things that I remember was from my MBBS days. If you all remember the Bailey and Love that used to be there as a surgical textbook, there was a comment there which said that abdomen is a Pandora's box, and then something of that I learned every day whenever we see dyspepsia. Is such a very common symptom, but it can entail so many of disorders and so many different presentations, is that today we really have to learn it in much more detail. So when we talk of dyspepsia, let's start with a simple case first. So this is a 55-year-old present lady who has come to our OPD with upper abdominal discomfort for last 4 months. There is some pain, some early satiety as soon as she eats. She complains of a non-significant 3 kg weight loss in 2 months. There is some diarrhea which is happening for last few years, intermittent diarrhea, although no alarm features like GI bleed or anemia. She is diabetic hypertensive for 5 years, and she is well managed with metformin and olmesartan. She has taken PPIs and prokinetics and everything for last couple of months, but there's no significant benefit. So this is a very routine kind of a case that I think we all as physicians would be seeing in our daily practice. And when we actually think of what can go wrong or what is the problem here, it's a huge list. It can be right from GERD, which is something like a functional dyspepsia or a gastroparesis, to something much more serious like a gastric malignancy. It's very hard to just go by symptomatology and try to differentiate which patient has what and to what extent do you test them. Now, symptoms can mislead because, as I say, that dyspepsia has a lot of overlap. This is from one of our textbooks, and you can see a huge list. So, what as doctors we have to do? We have to find these islands of organicity in a sea of functionality. That's what I commonly, tell my all of the fellows who want to learn GI motilities, that there are islands of organicity which will be in a sea of functionality. So that's where dyspepsia actually lies. So agenda is we'll try to define it, see the context, what is serious, what is not serious, what is happening in India, what are the common symptoms associated around dyspepsia, what are the pathophysiological processes, and how we can diagnose it. So the word dyspepsia itself is coming from the Greek word for maldigestion. So it was first described in 18th century in Scotland actually, but it attributes to a constellation of symptoms which is referable to the gastroduodenal tract, that means the proximal GI tract of a human. So it is a relapsing, remitting, and a chronic illness, particularly when we are talking about functional dyspepsia. But dyspepsia as a term can be a lot of things. It's common and it is expensive across the world. Why I say so? Because PPIs are probably the commonest drug that are used for functional dyspepsia, and it's a huge market. Even in 23, it was almost 10 billion, and over the counter, it's probably more than 15 billion now. So what are the terminologies? When this patient came to you, that middle-aged lady, it was an uninvestigated dyspepsia. You will examine the lady, you will do some investigations. In 30%, you'll probably end up finding some cause for it, which can be GI cause or non-GI cause, whereas 70% would be what we are trying to discuss today as functional dyspepsia. When we talk of those 30% organic causes, you will find things like Helicobacter pylori, you will find peptic ulcer disease. Rarely you may find a GI malignancy. In pancreatobiliary, you can find both acute and chronic pancreatitis, sometimes presenting only as a mild discomfort. And diseases like CA pancreas, gallstone disease in an early area will not really have those classical features of jaundice or pain. They may just have some discomfort. So coming back to our case, we have done our physical examination. She is slightly obese, 28 BMI, borderline overweight. Rest is unremarkable. We did endoscopy and an ultrasound, which was normal. There was some atrophy in the second part of the duodenum, and we took a biopsy. H. pylori was negative. The labs were normal, and HbA1c was okay, not so bad at all. Now, what do we do more? So, do we now consider this as functional dyspepsia? Are we happy that Lokeshi falls into that 70% of that category? Maybe yes, but let's try to define that now. So, functional dyspepsia has had so many definitions over the years. The current iteration of that is in the Rome 4, which divides it into two broad categories. That is the epigastric pain syndrome as well as the postprandial distress syndrome. Now, this is a symptom-based classification. If you're a pain predominant patient, that is the epigastric pain syndrome. You have a postprandial bloating predominant patient, that is a PDS syndrome. So by pure definition, it has to be more than 3 days in a week or more than 1 day in a week. But for all practical purposes, I'll say do not be very hard and fast on these definitions coming in from Rome 4. They are mainly there for the research tool. But both of these patients can be there, and there are a subset of patients who will have overlap. Apart from the Rome 4, there are ACG guidelines, there are Asia Pacific guidelines, but they are, as I said, they are not very specific. Just remember all the symptoms coming in from the gastroduodenal area that can be in the umbrella term of functional dyspepsia. So EPS and PPDS is somewhere around 1/3, whereas a combination of both of them can happen in almost 35 to 40% of patients who present to you in your daily practice. In India, how do we see? So there have been two major studies. We have one by Dr. Uday Ghoshal sir, we have one by Dr. Shah. They are good in numbers. One is primarily in the rural setting, one is from the urban setting. And if you really see the details of it, you will see that both of them in India, a combination of epigastric pain and postprandial distress is seen. There is no real rural-urban divide here. Whereas, isolated cases of epigastric pain is 9 and 17% only. So majorly our patients will have postprandial distress syndrome, and they will, of course, as expected, overlap with irritable bowel syndrome also. Now, when we talk of overlap, you have to see that functional dyspepsia is a kind of disorders of gut-brain interaction. And when we say that, we have to understand that there would be overlap with things like IBS, functional constipation. Now, coming on to why it happens. So as we said, it's a gut-brain axis disruption. So you need to have multifactorial things into play. So all of those things like visceral hypersensitivity, impaired motility, mucosal permeability, altered microbiota, they are the ones which are the triggers in a patient who is genetically predisposed and has associated central factors, stress and anxiety. So it is a disease occurring at multiple levels like any other DGBI. And there are proven things like higher eosinophils, higher colonic inflammation, or higher duodenal inflammation, even in patients who have functional dyspepsia. Now, broadly, when we talk of the motility, which is also impaired in these set of patients, you can have impaired gastric accommodation and delayed gastric emptying. So stomach has two broad functions. It has to receive the food and accommodate it first. And secondly, once it has accommodated the food, it has to push it down. So if there is any impairment happening at both these levels, that means patient can't accommodate large amount of food, or there is a difficulty in pushing it forward, both of them can happen and cause problems like functional dyspepsia. Now, duodenum itself also has a role. Whenever there is impaired accommodation or increased sensitivity, there is a slower gastric emptying. In a slower gastric emptying, you have higher acid exposure in the duodenum, and that actually leads to abnormal inflammation and responses to hormones. That itself also causes a lot of these symptoms. And why we talk about this today? Because this has been proven beyond doubt in at least 4 or 5 studies that duodenal eosinophils and mast cells play a strong role in patients who have functional dyspepsia. But we have also seen that they do not correlate well with the symptom severity. We have just seen that there is higher in patients who have pain predominant disease. Now, coming on to the next pathophysiology, that is the visceral hypersensitivity, that also has been proved that in patients who have functional dyspepsia, the visceral distension of stomach really causes symptoms much more as compared to patients who do not have these. Now, how do you evaluate them? You go to the history. I think history is something which is very, very important here. You look at the symptoms, what is the predominant mechanism or predominant abnormality in your patient, whether it is epigastric pain, whether it is distress. If it is pain, look at the duodenum. If it is postprandial distress, look at the stomach. Look at systemic illnesses like diabetes, thyroid, hypertension, systemic sclerosis, autoimmune disorders. Look at what the drugs our patients are taking, because a lot of these symptoms are also triggered by drugs. What kind of diet they are on? Do they have any GI infections like Giardia in the duodenum? What kind of stress or alarm features that they are presenting? So this is probably the single most important thing you can do is listen to your patient. What are the alarm features? Yes, where you will require an endoscopy. We all know that in India, age around 60 years, GI bleeding, anemia, dysphagia or dinophagia, vomiting, unintentional weight loss, some lumps, all of them will, lead you to a lower threshold to do endoscopy. In physical examination, if you find anything higher BMI, icterus, lymphadenopathy, please don't wait. Scope them or at least test them for something much more serious. A basic investigation set would be at least a hemogram, a LFT, a renal function test, an ultrasound, and things like thyroid and HbA1c. Now, who needs endoscopy? I think the commonest question asked is why should we scope everybody, or should we choose whom to scope? Now, as you can see, this table where we divide West India and the East, we have seen that in India we have much more higher H. pylori prevalence, although the gastric malignancy is relatively less in India as compared to the East. But most of the malignancies that we see are all, particularly stomach, are akin to the one in the East, that is the age is around less than 40 years. But the most important thing you need to see is that our survival is only 6%. That is why in India, I think it's important to scope these patients who have even a small alarm symptoms or no significant relief. And for us, the age cutoff should be around 40 years. And why do you see? You will see all these things. These are good high definition NBI images of early gastric cancer. It's also an opportunity for you to check for H. pylori, whether it is an H. pylori associated dyspepsia, and you can diagnose other conditions as well. So, but the problem is that, as all of us, we will know, 70% will have normal endoscopy. So the caveat usually people say is that, okay, the endoscopy is almost always normal. Yes, it is normal. But the other 30% where you will pick up something wrong is worth scoping all those patients. How do you manage them? I think Dr. Rinkesh will cover them in much more detail. I'll just briefly touch on the, a very broad guideline to it. If you have alarm features or age more than 40, do an endoscopy. Find out if they have H. pylori. And as well as you can go for an empirical treatment if there are no alarm features. Identify food triggers. So there are no standardized guidelines for functional dyspepsia as compared to IBS, but ask your patient to maintain a food diary, see their dietary patterns, look into their herbal supplements. A lot of them are on different supplements which should be stopped. You can test them in an advanced way. If you really have a bad patient who is not responding at all, you can do things like gastric emptying time. You can do an enteroduodenal manometry, and you can really see if they lie in that gastroparesis spectrum. Remember, patients of functional dyspepsia may have abnormal gastric emptying time. And if it's, it's a spectrum that continues towards a severe gastroparesis where better treatment options like GPOM or pyloroplasty are available. So how do you approach them? Alarm, we already like discussed, I'll quickly run through them. Alarm features, endoscopy, H. pylori higher than test, 10% like in India, treat for H. pylori. If you still have patients who have a PPI, that means postprandial distress, give them PPIs because as we talked, the duodenal eosinophils play a role and PPIs have a degranulation effect on the duodenum. If not, there are better agents which I think Dr. Rikesh sir will discuss. So coming back to our case, remember we took a biopsy in the second part of the duodenum and we were till now treating as functional dyspepsia and patient had not got better. We were trying to treat them with another set of PPIs. We had given them prokinetics. We had given them tryptomer. Patient was not improving. But the biopsy came back and it showed villi blunting with increased lymphocytes. Now TTG is normal, but this is the biopsy. Now going back to your history again, as I said, the history is the single most important factor. Identify a drug which has been being used in these set of patients and patient intermittent diarrhea. So olmesartan is something which is very, very important as a cause of such symptoms and cause enteropathy. Olmesartan induced enteropathy was a diagnosis in this patient. It was stopped and patient improved. So the whole point of showing this case was that in the history itself, you will find a lot of small clues which will help you to diagnose what is important, what is not. So to take home points are you make a positive diagnosis, take a detailed history. There are significant overlaps. Gastric emptying time is available, but it may not correlate with symptoms. Endoscopy, take biopsies, look for eosinophils, lymphocytes. Remember the drugs that patients are on because a lot of these patients will be on multiple drugs. Assess for food triggers, think of elimination diet, treat for H. pylori if present, and first line therapy is PPI, particularly if you have a patient who has a postprandial distress or a pain. And then finally, there are better drugs which are also available. So functional is not an equal to a lack of abnormality. So what we today consider both of them, functional dyspepsia and gastroparesis, is as a severity continuum, and there are definitive clues in the endoscopy in the history where we can identify what to do better. Thank you so much.
Thank you, Dr. Zubin. That was wonderful, actually short but very clear. There are a lot of questions, of course, I have. I'm a physician, so I find this a very difficult clinical problem. But I'll wait because I hope that Rinkesh will cover quite a few of them and then we'll take it further. So, how to manage them? So, Dr. Rinkesh, I've already introduced him to you, and he'll be taking us through how to manage this very difficult set of problems. Dr. Rinkesh, over to you.
Thank you, sir. Thanks, Lupin, for nice talk on Friday evening. Very important topic, and Jubin rightly set the stage and nicely covered the importance of the history and the subsequent line of investigations. So my job is to cover the medicational part, the fundus relaxant and prokinetics. What are their place in therapy? So we know that greeting from the Fortis, and we know that there are treatment options in functional dyspepsia. Mostly when the patient is positive, we give the H. pylori eradication therapy, triple or quadruple, depending on the patient's status. Then there are some medications we know H2 receptor antagonist, proton pump inhibitors, and now PCAB with the quite good experience in India also. We have some antacid syrup, raft syrup, and other things. And the most important, which is the point of discussion today, and there is a lot of controversy regarding the use of prokinetics. So I will cover in next 5 to 10 minutes about the role of prokinetics. So rest we know that it required. So when we start the treatment for functional dyspepsia, it is the PPI or nowadays some other molecules like PCABs and RAF therapy. So we start with the PPI, and if the PPI are effective, we continue PPI for durations. But when there is a PPI refractory patient, we add some additional therapy. It may be prokinetic, it may be other things. So we need to identify the patients who will respond to the prokinetics. So this is a quite important cartoon in which when the patients have reflex symptoms, so the most important thing, the patient presentation. As Jubin rightly said, if the patients had reflex symptom, we start prokinetic from the beginning. But when the patients have dyspeptic symptom, we initially gives PPI alone, and in the second week, we after second week we add prokinetics. So now there are lots of prokinetics available in the markets, and right from the cisapride and until recent one, there are some limitations. The main limitations are the side effects. Cisapride has some cardiac side effect, then mojapride and etopride were not superior to placebo in early phases of clinical trial, though etopride have some data nowadays, and we use in some patients. The issue with the most common used levosulfide is the prolactin increase, galactorrhea, and change in libido, and that's why levosulfide and probability of Parkinsonism also. So that's why we should avoid at least for long therapy, and we should monitor these type of side effect. If we find that these are side effects are happening, then we should stop medication immediately. Most of the time they are reversible. Domperidone, which is used very commonly, also have safety issue, specifically QT prolongation, and sometimes a sudden cardiac death or cardiac arrhythmia also noted. So we should avoid this domperidone in specifically cardiac patients or kidney patients, just to avoid cardiac complications. Metoclopramide and domperidone are evidence are lacking in functional dyspepsia. There are some data about the other prokinetics like etoprides, prucaloprides, but in functional dyspepsia, this is not so commonly stated. So the now is the role of ecosiamide. Uh, Again, this is also used as a prokinetics. It has the gastric accommodation enhancement as well as the gastric emptying, and it improves the fundus relaxations, and it increases the enteral motility. That's why it propel the food towards the duodenum. So we use ecosiamide 100 mg thrice daily before meal, and it is approved for treatment of meal-related functional dyspepsia, specifically the postprandial fullness, early satiety, and bloating. And most of the ecosiamide works well in specifically in the patient with diabetes. So there are some studies, some short-term study as well long-term study, in which they are used quite commonly. So this is the 2-week gastric scintigraphy study in functional dyspepsia, and there is a significant improvement. Ecosiamide also used in another trials in different part of world, in Japan and in European countries, and it has some specific specific effects in postprandial distress syndrome patients. Now the long-term data, safety and efficacy of ecosiamide. So there are some studies for at least for 1 year data, and the efficacy as well as the side effect profile were quite good, and there were no such significant side effect noted with these molecules. So functional dyspepsia symptom generally started to improve from early stage of treatment with the prokinetics. So we should use prokinetics in the early phases, and the improvements effect was maintained even after the dose interruptions, and adverse reactions are quite less, specifically with the ecosiamide. to summarize, therapeutic options for patients with functional dyspepsia are limited. We should use prokinetics specifically for short durations. We should not we should avoid the combination medicine, and we should avoid the long term prokinetics. There are some safe prokinetics like ecosamiide or etopride in comparison to others, and there are availability of these molecules in the market easily, and there are lots of studies nowadays in India and outside the India in which they are relatively safe, but they should be used judiciously and for a limited durations. And along with the PPI and prokinetic, the team efforts is always required. So we have the very eminent leader, Dr. Gordas, and my dear Dr. Jubin and others in our team. And thank you very much. I will be happy to answer any questions.
Thank you, Dr. Rinkesh. I think that was wonderful. Dr. Gajanan, are there any questions or should I fire off? I have quite a few questions which I want clarification on from these two experts. In my day-to-day practice, I have these problems. Dr. Gajanan,
I
have you
think,
got
yes,
any questions?
sir. What I feel, I think you first interact with the speakers.
Okay.
There are questions we have received, but we'll take those questions once.
Yeah. And then I'll ask you, you can actually
Yes.
pose those questions on behalf of the doctors who have asked, okay?
Yes.
So, okay. So let me first start with a very common problem that I face day to day, Dr. Zubin and Dr. Rinkesh. So one of them is, the example that you gave, Dr. Zubin, 50-odd-year-old woman with a 3 kg weight loss, okay, persistent dyspepsia. So when you ask for an endoscopy, primarily, I'm sure the person must have taken a PPI, by that time somebody has given it. So when you are actually doing endoscopy, what would be at the back of your mind? Would it be that, look, since cancer is a possibility and you don't want it to be overlooked, because, I think waiting for a lump and drop in hemoglobin is always implies that it's a late stage. So you have the person scoped and the report comes as there is no cancer, there is no ulcer. In the meantime, during your interaction, you have discovered that she is undergoing stress because her daughter is giving her boards, class 12 exams. So here, during endoscopy, there is nothing alarming, but it comes out with a H. pylori positive, so RUT positive, okay? Now, I want it in a very balanced way, not theoretical, okay? So in India, roughly in your practice, when you scope and do a RUT, what proportion of patients do you find are positive on the RUT test, the rapid urease test?
Almost 70 to 80% are positive with rapid urease. Yeah.
Now, if you get a person of this type who is RUT positive, how likely are you to believe that it's the H. pylori infection which is causing the dyspepsia rather than the stress? So that's one question. And then would you offer treatment for H. pylori right there? I mean, the implications of my question, I wanted to be clear to all the audience. We are caught in a trap. The therapy implications are you have to give 2 antibiotics, usually clarithromycin and amoxicillin, for 14 days, and the doses are pretty high. And most of them who tolerate it, they would anyway feel nice if they have survived those 2 weeks. Okay. So is the benefit indeed related to the H. pylori going away, or is it because we have found something as something to blame so that we can put our finger on it? So how do you manage these patients?
There are two things I look at on endoscopy apart from the RUT in these set of patients. One thing is that, is it my incidental finding of H. pylori? Okay, I took an RUT and it is positive. Or there are changes on endoscopy, like atrophic is there, or some duodenal ulcerations are there, or some definitive gastritis is there. If I have an independent indication to start H. pylori based on these findings, I will treat them, because then they can be harboring the symptoms because of that. theoretically, again, I'll say that yes, the definition of functional dyspepsia would merit that we have excluded an H. pylori associated dyspepsia. But practically, if my patient, history-wise is sounding like it's more of an anxiety or a stress-related disorder, and there are no such findings on an endoscopy apart from the incidental RUT, I'll probably wait before I treat for H. pylori. I'll probably give them more counseling and offer them symptomatic based management with ecoshiamide or other prokinetics, and then see if I really need to treat any more than that.
Oh, good, thank you. May I pose the same question to Dr. Rinkesh? So, Rinkesh, difficult problem, as you know, day-to-day practice. See, the question is that when you treat patients with H. pylori infection and dyspepsia, in my practice, I find that about a third of them come back feeling that, yeah, after H. pylori treatment, I am better. But at least 2/3, they don't improve and they think that the ordeal of treatment has been high. Number two, as a senior physician, you know that our incidence of C. diff infections, Clostridium difficile infections are going up. In the last 3 weeks, I think we saw about 3 patients of C. diff, if you remember, you and I. And, with very little provocations, none of that clindamycin story. So are we likely to create problems with a long-term therapy of H. pylori, or how do you draw the balance?
Sir, very important question. And yes, sir, regarding that antibiotic usage in every indication, in fact, there are lots of unnecessary antibiotic usage are there, and specifically in H. pylori, we are as a gastroenterologist or as a physician, we are using more than required. The issue is, yes, with the like Dr. Jobin said, that there are some particular indication. H. pylori alone is not should be the indication for H. pylori treatment. There should be some changes along with the H. pylori RUT positivity, some typical atrophic changes or ulcerations, which we can contribute to the H. pylori. Then we should treat with the standard regime. But if there is a nothing specific finding, then I think we should just wait and watch. Sometime these patient, as you rightly said, 1/3 improves with the antibiotic, but if we wait, that 1/3 also improve without any antibiotic or any H. pylori medications. So I think we should wait, sir, if there are no alarming
I think
symptoms.
that physicians are actually, they know their patients very well and they can take their discrete decisions. But anyway, I just wanted to bring out a flavor of how difficult it can be. There's a question from Dr. Girija Nair. Hello, Dr. Nair. So patients don't get results in 1 to 2 weeks if they don't get it. So how long it takes to get complete relief? So that's one question. So whenever you treat dyspepsia, what's a fair time that you would think that the relief should come, if at all it does?
Generally, I think 2 weeks is sufficient, sir.
Your thoughts, Zubin? I remember seeing that study on ecoshiamide long time ago, and I think the graph started improving after a fairly longish lag period. What I'm trying to tell you is that the response may not be very quick, as people might like to believe that within 24 to 48 hours. So what would be a reasonable time before you call the patient back to say there is no response?
So when I start them on PPI and ecoshiamide combination, I usually bring them back at 4 weeks. I want at least a month going in before I investigate any more than what I have already done at point of.
So if that's your question, let me ask you a more vexing question on behalf of Dr. Girija Nair. So if the person comes at 2 weeks and they're not feeling any better at all,
Yep.
with ecoshiamide and a PPI, what would you then advise?
So that then I will, do more investigations. Even if they come back at 2 weeks and they are not even slightly better, or they are at, worse than what they were to begin with, and the symptomatology tells me that patient has more of an epigastric pain, in that case, I will definitely go in with better imaging also, if it's a pain predominant disease, and if it's a distress predominant disease, probably biopsies from second part of the aorta.
Okay. So Dr. Nair, I hope you'll thank me. I've on your behalf, I have taken on the two stalwarts in a big way. Dr. Shahidul from Lakhimpur Kheri, that's near my hometown here, Lucknow. So, Dr. Shahidul, his question is how a physician can differentiate PDS and EPS clinically. Anyone?
So EPS is an epigastric pain syndrome. So if the majority of your patient's symptom are pain predominant, that is pain increasing after food intake, that would fall under the EPS. And if it is postprandial bloating, that becomes as a predominant feature, that patient feels very full after eating, or he can eat only small amount and he feels very full. That will come under the postprandial distress syndrome. But as showed in the slides, there is almost 40% overlap between these features, and sometimes it can be hard for a patient to differentiate pain versus distension. So, we have to take that with a pinch of salt.
So, I mean, in most, if you ask around or give them enough time to talk, they'll probably tell both the two symptoms,
Yes, sir.
Yes.
Sir.
You might actually therefore have to manage it that way. There's a very interesting question from Dr. Ashok Kumar Yadav from Darbhanga. What's the diagnostic investigation for fundus accommodation abnormality?
So the simplest test that you can do is have a full glass of 200 ml of water in your OPD and ask the patient to drink it in front of you in a very fast way. If they can drink 200 to 50 ml of water upfront without any discomfort, that's a good screening test. But if you want a better objective way of knowing gastric accommodation, then the only test, there are two tests. One is viable India, one is not. One is a EGG, that is an electrogastrography, which has a water load inbuilt into its way of testing. The second is a gastric barostat, which was probably there, I think, with Sir when Sir was in SDPGI, but currently I don't think it's there in India anymore.
Yeah, okay. So the diagnosis by way of investigations is a little cumbersome.
Yes,
Most
sir.
of it is actually done in advanced physiology labs, more as a trying to understand the mechanism.
Research tool, yes, sir. Yes, sir.
Yeah, very limited availability.
Day-to-day practice. Dr. Arun Kumar Chaudhary, how should first-line therapy be tailored for functional dyspepsia patient based on symptoms presentation? So his question is PPI, prokinetics, acosciamide, neuromodulators, how would you kind of sequence them or use them in a clinical setting? Any one of you?
So when there is a both the symptom, I think we should start with the PP and prokinetic together. If there is a only epigastric pain predominant symptom, then PPI or PCAB alone is sufficient.
I mean, most of the time we start with the acid suppressant, and then after that, the other one is an add-on. Am I right? That's what we normally would do. So, Dr. Khushi is from Surat. He wants to know, how long acosciamide needs to be prescribed to a patient for functional dyspepsia. So, I think part of it you answered that it would take at least about a month before you get a significant assessment of response. But let's presume that the person does respond and say at 2 months or 3 months they're well. Then how do you manage? In the sense, do you give it long term? If long term, how long term? And so on and so forth. What are your thoughts?
Generally, sir, prokinetics, though there is a data about the safety, so specifically acosciamide for 1 year, but I think in a stretch, what I practice in 12 to 24 week at a stretch, and then I try to avoid prolongations of prokinetic specifically.
I mean, my thoughts are that PPIs usually come around 6 rupees or so per day cost minimum, I guess. Some go up to 12, and then acosciamide 3 times a day is reasonably expensive. I mean, in that sense, it's not very cheap. Anyway, Dr. Neet Lakhani from Nadiad. So, when should a patient refer functional dyspepsia patient to a gastroenterologist? Very important question.
A patient who has any alarm signs that we enlisted, a patient who is not responding to standard PPIs, a trial of PPIs for at least 4 weeks, a patient who is losing weight irrespective of his symptoms, that's where I will probably refer them to a gastroenterologist for a better testing, particularly thinking that the patient is not part of the routine functional dyspepsia. And second would be, a lot of these patients are tough to treat in the sense that they will have significant overlap. So they will have constipation, they will have IBS kind of features. So when you have those multifactorial patients who have functional dyspepsia, bloating, IBS, constipation, everything coming together, that's where you have to refer them because they need a better detailed management in terms of their medical part.
The second question which I'm going to pose now is linked with the previous one. So Dr. Anirban Ganguly, so he's asking, how do you differentiate between postprandial distress syndrome and epigastric pain syndrome? That's first. The more important question, in a patient under 50 without red flags, when do you choose empiric treatment versus upper endoscopy?
Yeah. So I think the first part of the question regarding differentiating, as I said previously, I think it depends on you. I asked my patient upfront, majorly, what do you feel? So in the end, they will probably come down to a symptom, either it's a pain predominant or a distension predominant. Otherwise, if there's overlap, it's still okay. But the only way to differentiate is history. Coming on to the second question, that below 50, if you have a patient who has functional dyspepsia and no alarm features, you can give an empirical. So there was a study which looked into an empirical trial versus an endoscopy based treatment. And there was, acceptance on both the sides. But this study was coming in from the West where endoscopy was still okay. In India, I will give them at least 4 to 6 weeks of decent trial before I ask for a endoscopy in case there are no alarm features. So a good 4 weeks is good enough to check for that below 50 years of age.
What I do in my practice is that you asked two questions, no? Zubin, you said these
Yes,
are
sir.
the questions you asked. I ask a third question. And the third question is that, tell me, so that's your symptom, but what is your worry?
Mhm.
And I think that's a very important question. If that patient tells me that I think something is going on there, I have an ulcer or do I have a cancer, then it's much better to get the test done so that
Yes,
he's
yes,
also reassured, you're also reassured. I mean, why take
absolutely,
the risk of missing something? So that's
absolutely.
the third question which I asked. Okay, so now I have Dr. Parthasarthi. Is acoshamide safe in elderly patients or those with comorbidities? Dr.
Yes,
Your thoughts?
yes, sir. So it is safe. There is no extrapyramidal symptoms regarding this. No cardiac side effects were noted. So Acosamide is safe. Yes, it's a more important in a patients who have diabetic gastroparesis particularly. But again, in term of side effect, it is relatively safe Procaine.
Dr. Dhanjit from Guwahati wants to know, how can a physician differentiate FD from organic causes of dyspepsia such as peptic ulcer disease or GERD? Anybody?
So the alarm features is the first thing, but having said that, I also would like to say that some of these alarm features do come in quite late into the natural history of the disease. So I think the single most important factor would be if you have a patient who is not improving with PPIs and prokinetics, you're given it for a couple of weeks, above 50 years of age, that's where you should start thinking of organic causes. I think that's something which should be there in, as a single message to probably all of us.
So Dr. Dhanjit asks a further question. What biomarkers or endoscopic findings can assist in ruling out other GI conditions mimicking FT?
On endoscopy, the first, you can see a lot of things. You can starting from esophagus itself, you can think of all the conditions of esophagus like eosinophilic reflux disease, GER lax LES. Coming into stomach, you can look for things like gastric malignancies, atrophic gastritis, metaplastic changes in stomach. In duodenum, you can look for duodenal ulcers. You can look for any atrophy in the second part of the duodenum, any fissuring, things like celiac disease, GRDSS, eosinophil. So there's a huge list. which on endoscopy we look for, and most of them are to rule out other things which may mimic dyspepsia. And actually, the definition of functional dyspepsia would entail that we rule out all these things. So on endoscopy, there are a lot of things which we look into, but as I said, 70% would be normal in cases of functional dyspepsia.
Yeah, I might just add that sometimes, although the dyspepsia points to the stomach or the upper GI,
Yes, sir.
sometimes the causes can be lying outside the upper GI.
Absolutely, sir.
Neurological disorders, hormonal disorders, diabetes. So, sometimes those actually have an impact.
Yes,
And
yes.
looking into the stomach may not always be rewarding.
Absolutely, sir.
Very good. Then we have Dr. Shekhar Saha, another very important question. Any vitamin deficiency related to dyspepsia?
B12 deficiency can happen if there is a significant atrophy in the stomach because of lack of intrinsic factor or an autoimmune gastritis, but only upfront functional dyspepsia presenting as B12 deficiency or some other deficiency is less likely.
May I add for the physicians, that PPI use, especially acid suppressants and PPI use, is associated with a few deficiency states. So there is an impaired iron absorption, impaired vitamin D absorption, impaired B12 absorption. So these deficiencies can occur. Especially the omeprazole group has been known to be associated with hypomagnesemia in certain cases. So just for completing the list, these are some of the things which you might keep in mind. The question is which is the cause and which is the effect. So sometimes they are more a consequence of long-term PPI use. So as long as you understand how to fit it into the chronology of your patient symptoms. So then we have Dr. Sanjeev Banik. Can we use vonoprazan and ecoshiamide combination in long-standing GERD? Very important question. You know why? Because ecoshiamide, whatever you talked about, you didn't talk about the LES. And GERD, we seem to believe that the problem seems to be with the lower esophageal sphincter not being tight enough. So, your thoughts on that?
So, in my opinion, the adding ecoshiamide over the along with the vonoprazan will not a beneficial in GERD because the ecoshiamide generally it's as you said, sir, it's not functions on the G junction. It is more for funding relaxation and the enteral motility related things. So, I don't think it will add some benefit.
So, Rinkesh, can I ask you, because you are into a lot of therapies also, all the prokinetics that we have, so starting from what have you, domperidone probably is the only exception. So, your etopride, cisapride, mosapride, lesuride, levosulpride, none of them are actually approved by the FDA for marketing or for use in the United States. Okay, and everybody knows that FDA has a fairly strict and stringent rule for approval. We seem to find them very useful because they do work on the lower esophageal sphincter.
Yes, sir.
So how do you actually deal with this or reconcile with this dichotomy that they don't seem to be safe enough for the Americans to use in their country, but we seem to find it useful and we use it quite frequently, and they're pretty good with regard to providing comfort. So how do you navigate through this?
Sir, specifically these prokinetics should be used in selected period, like 12 weeks is more than sufficient, and we should avoid the combination medicine, which is a fashion nowadays, and we should give in divided dosage. And yes, it's not approved in US, but in India we see in our practice that the patient who have LES problem, they improve with the adding of prokinetics. So it should be reasonably for time limited, and it should not be the combination medicine. That's all.
Good. Then Dr. Paresh from Ahmedabad. If ecoshiamide is a fundus relaxant that improves gastric accommodation, how does it also enhance gastric emptying? Very important question. Zubin, you want to take that little bit?
Yes, sir.
Territory? Yeah.
So ecoshiamide is technically an acetylcholinesterase inhibitor. So it does increase the acetylcholine levels. it not only is a fundic relaxer, it does push the muscles in the gastric body. So that's how it actually also works as enhancing gastric emptying. So the maximum amount of acetylcholine receptor is in the fundus. So its predominant mechanism is there, but the body also is, works. So there is some increased motility. It doesn't work in the interim per se. That's where the other prokinetics would probably work in a better way. And coming on to sir, your previous question on the FDA. So US has not improved any prokinetic except probably domperidone for so many years. And a lot of the patients, they take these drugs like Ganadon or Ecoshamide from outside US. I think the problem is that there not been enough trials in US for all these safer prokinetics, whereas the previous ones like Cisapride and Musapride, the experience was pretty bad with a lot of extrapyramidal symptoms in US. So that's why they take almost all prokinetics with a very significant eye, and they don't approve it very easily.
Yeah, but to be fair to them, after all, the PCABs they have actually approved pretty well.
Yes.
Which give it to them. And one question last, which has just dropped up, Dr. Kaushal Kumar, combining PPI and Ecoshamide and renal safety. So there has been concern about the renal safety of proton pump inhibitors. So does Ecoshamide make it worse or make it better, or no change?
No change, sir. But yes, long-term PPI have some renal issues, and I think we should consider in again in renal patients it should be considered for limited duration, sir.
Now, may I ask a provocative question? It bothers me day to day. Is PCAB safer for renal from the renal safety point of view than PPI? I don't know about the recent data.
I think even PPIs are very. I mean, we talk of renal injuries with interstitial nephritis happening with PPIs, but I'm yet to see one, and I'm yet to hear from a nephrologist who is saying, okay, this is a proven PPI induced interstitial nephritis. So PCABs, I think I will not say they are safer; they are equal to it, PPIs, but theoretically, as again studies would say they are safer, but practical all purposes, I think they are equal to PPIs.
I'll invite you to one of the sessions where we have the people coming down from the Royal College of Physicians of England. In England, all the nephrologists seem to think that their worst enemies is actually PPI. And the major part of the discussions go around the renal safety or the lack of it with PPIs. Indians say that we don't see it. They usually point their fingers back at us and say that we don't look hard enough. So that's the usual story that is raging, but I just thought I'll be provocative before we close. I think that was a very fascinating discussion. If there are no other questions, Dr. Gajanand, can I ask you to come over and take over from me and then give your closing remarks if you have anything else to add? I think you now understand that what a wonderful team I have, So Dr. Rinkesh and Dr. Zubin, and they keep guiding me and teaching me every day. Over to you, Dr. Gajanand.
Thank you, sir. Yes, thank you, sir. So now, as we have come to the end of today's event, I take the opportunity to thank everyone on behalf of Lupin. So first of all, I thank Dr. Professor Gaurav Chaudhary for accepting our invitation to moderate this session, to chair this event today. So thank you, sir, for chairing the session and leading the scientific discussion. Also, I thank our speakers, Dr. Zubin and Dr. Rinkesh, for their wonderful talk on very relevant topic and for insightful discussion also. I also thank our audience for posting their interesting and intriguing questions, and thank our faculties for patiently answering the questions. So I thank everyone for making today's event a success. So with this, good evening and have a great time ahead.
A big round of applause to the questions, to the audience.
Yes,
big round of applause to the audience.
Yes, truly. Because of which actually very much insightful discussion also happened over the questions. Thanks everyone.
Thank you so much.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir. Thank you,
all.
everyone.
Thank you,
Thank you.
doctors, for making this event successful. And I'm really glad
Thank
to
you.
share that we have already crossed 1,000 plus of doctors, speakers, consulting physicians who are listening to us. And thank you here from the Lupin family. Thanks a lot. Thanks a lot to all the doctors. And looking forward for such a more insightful events and webinars with doctors.
Thank you so
Thank
much.
you. Thank you. Thank you,
Thank
doctor.
you. Thank you.
Thank you.
Bye. Bye, everyone.
Bye.
Thank you so
Yeah.
much.
Bye.
So
Thank you.
from here, I'm ending this meeting. Thank you.
Yes. Yeah, you can end the session.